Good morning. We're going to go ahead and get started. We're right at 9 o'clock. I know people will probably filter in, but I don't want to waste any time because we have quite a bit of material to get through today relating to design of experiments. We'll do just a little bit of RStudio at the end, basically to show you that it has some capabilities to power an analysis, so I'm going to use it to facilitate demonstrating a simple power calculation. The majority of the RStudio analysis, though, will come the next 2 weeks. If you're interested in looking at previous lectures, they will be posted. Actually, the first one is posted at our departmental webpage, biostatistics.kumc.edu. On the left-hand side, you'll see events and lectures. If you visit that events and lectures link. Looks like we're having a problem with the online group here in the audio. In one moment. Probably change the microphone, select microphone, chat. Apologies for that. If you are able to visit this webpage under events and lectures, here's the link, Introduction to Biostatistics for Clinical and Translational Researchers. There you'll find links to the recordings from last time, and those will be posted generally within a day or two of the previous, of the lecture actually being given. Before we go any further, are there any questions about the material that we covered last time? No? Okay. Again, just to reiterate the course objectives, I'm not trying to make you a statistician. I'm just trying to give you a little bit of appreciation for the role statistics can play in the scientific process, whether it be through the designing of a study or determining what observations or what measurements to collect, how you're going to collect them, to deciding on the analytic method, understanding how results relate back to the context that generated the data, and then, of course, interpretation of your findings. So basically, just to make you a little bit more fluent in the language of statistics when it comes to your own research. Today, we're really going to focus on designing experiments. In other words, what are the different scenarios that we could select from in terms of how we assign our treatments to subjects, how we collect data on those subjects, and what analytic methods are appropriate. We'll have an example at the very end regarding a simple power calculation, basically just to introduce you to RStudio and to the concept of how sample size relates to the power of a study. In the next 2 weeks, we're going to get into all of those different types of analytic methods that you're probably familiar with at some level. And then we'll do different applications of those to some common clinical research questions. So we'll cover things like chi-square tests, which are useful for looking at the distribution of a characteristic or a feature in a population, or maybe looking at the association between characteristics in a population. We'll look at t-tests, which are very good for trying to find differences in continuous responses between groups. We'll look at linear regression and correlation, which tries to look at how two features that are continuous are potentially associated, or maybe, depending on the context of the study, maybe one is causing changes or shifts in the other. And then we'll finish up with some things around survival analysis. Recall for a moment the definition of statistics as a science. Statistics is the science of decision-making in the presence of uncertainty. Last week we focused primarily on first determining what kind of information is contained in our data that we have from a study, and how that information dictates, along with maybe what questions we're addressing, what kind of methods, statistical methods, we would use to describe the data. So we covered things like summary statistics, the mean, the median, the standard deviation, the range. We also covered different graphical summaries like box plots, bar charts, and histograms. Today, again, we're going to focus on experimental design. Experimental design really is a set of methods and techniques and approaches to designing your study in order to ensure that when you get data back to address a research question, that data gives you an unbiased picture of what actually occurred, as unbiased as possible, and that it strengthens the conclusions of your study. Probably as an instructor and as a consulting statistician, one of the most common questions, aside from how many subjects do I need for my study, is how do I actually analyze the data that I have? The data could have been collected as an observational study, meaning you went back and you reviewed medical records and collected data on some interesting things that you were concerned were occurring in your patient population. Or it could have been from an actual design study where maybe I wasn't brought in as the statistician from day one, and so I have to learn more about the design of the study in order to give you that answer. But this is a question that I get very often. How do I analyze this data? It can be very straightforward in many, many scenarios and in many cases, but there are some cases where it can be complex. And I will say that I'm going to try to give you here a cookbook, but just know that cookbook needs a lot of user input, if that makes sense. Meaning I wouldn't give a cookbook to my daughter and ask her to go cook a French meal, because she just doesn't have, I think, the background or the experience to make modifications as necessary. Sometimes the data is so nice and the context is so straightforward that you can apply the cookbook and walk out with your grilled cheese perfectly made and it tastes great. But again, depending on the complexity of the situation, you may need to take a step back and recognize at some point that you may not be the person to make the decision about how you analyze your own data. The things that you need to take into account when you're trying to determine what analytic methods or techniques are most appropriate are the context that generated the data. What I mean by the context is, what's the design of the study? Is it observational? Is it retrospective? At what level is the data being collected? Is it collected on the individual patient, or is it collected more as a summary at the clinic level? Though that contextual information is vital, so you have to understand where the data came from. You also have to understand the specific type of question that you're trying to address. That seems pretty obvious, but sometimes it's something that we, in meetings, really kind of, we have to figure out what that question is. What's the denominator of this fraction that we're trying to estimate? We don't really know what our population necessarily is. What's the information contained in the measurement that you collected? So that links back to what we talked about last week in terms of levels of measurement of a variable. How much data do you have to work with? If you have 10 patients and you've got all this information on them, you're not going to be doing some sophisticated regression on 10 patients because you only have 10 observations, so it doesn't make sense to do that. And then, of course, the appropriateness of the method based on and I put in quotes here, the behavior of the data that you actually collected. Very often we have a continuous outcome, and we're trying to compare it between groups, and we say, well, this is a t-test. I learned this in my undergraduate statistics class, that if I'm trying to compare means, I need to use the t-test. But you have to look at the behavior of the data first. If you have very skewed distributions, or one group has much more variability in it than the other, the t-test will give you a result. It will give you a p-value and a test statistic, but those things are not actually testing what you think they're testing in that case. So you have to determine the appropriateness of the method based on its assumptions. Actually verify those assumptions with your data set first before you try to draw conclusions from the results of the method. So getting away from the verbose bulleted points, I'm giving it to you here in terms of statistical or research kind of terminology. The design of the experiment is the context. The question, which is the hypothesis, or the feature of a population you're trying to estimate. The level of measurement dictates the amount of information in a data point. The sample size and the assumptions of the method, like the t-test or regression. Experimental design includes several different components. I believe I included this last time. I have made some changes, so I can't recall if I removed this slide or not, but I wanted to go over some of this information. You have to have testable hypotheses. You have to be able to determine the different treatments that you're going to compare if you have treatments or interventions or populations. So what are the experimental conditions that define your group or your groups? What measurements are you going to collect? What other extraneous conditions are you going to control? If you know that gender could potentially impact your outcome, you have to figure out how you're going to control that. Either you're going to limit your sample to only males or only females, or you're going to somehow modify your randomization, regardless, you need to make sure that you have some way incorporated that into the design of your study. You have to, of course, determine the appropriate sample size for the study based on what you're actually trying to do with it. You have to make sure that you understand the population from which you're going to sample. That comes into play about what are you trying to generalize these results to? Is it this larger patient population, or is it a more specific subset of that population? Make sure that you're actually sampling from the population you're trying to infer about. Specify the procedure for assigning subjects to experimental conditions. That's randomization if possible, and there are different variations on randomizations that we'll talk about briefly today. And then, of course, determine the statistical analysis that will be performed. But again, the ultimate goal of all of these different techniques, which we lump into this statistical framework called experimental design, is just to provide you with increased chances of making a correct decision by incorporating techniques that minimize bias in the outcomes that you are measuring, and also ensuring that we have a sensitive test, a test that will actually show us a difference when it's actually there, or not give us a difference, not flag a difference when it doesn't exist. 3 common methods that are part of experimental design that I'll talk about briefly today are randomization, or random sampling, control groups, and blinding. When you're randomly sampling from a population, of course, you have to have your criteria well defined. There are different ways of sampling from a population. The preferred sampling technique is what's called a random sampling technique, where if you have a population that you're sampling from, every individual in that population has an equal chance of being selected. We never really have one of these, do we? We usually have what's called a convenience sample, which is defined as persons that are selected because they're convenient or readily available. These are the people, the patients that walk into our clinic or into our hospital, or whose medical records that we have available to us. So we use them, and for all intents and purposes, we could treat them as if they're a random sample, but we have to make sure that we understand maybe some limitations around that convenience sample that could affect how we generalize our results from our study. So a good example of this would be if I'm doing a study using medical records at a VA hospital. I have to understand what's the population that's actually being treated by the VA hospital. And is that population, can it be thought of as being reflective of the larger population of the United States? And I would say no, because they probably don't see pediatric patients. They may not see an equal number of men and women. They may have their age. The age of the population that they treat may be different from the age of the general U.S. population. So again, just understanding the context that generated the data can affect, not necessarily in that case, how you would analyze the data, but how you would try to apply the results of that data to some larger population. And it would need to be the population that you're actually sampling from. Systematic samples and stratified samples are other types of samples that we use, but generally the convenience sample is what we work with. Are there any questions around this concept? If we had a truly random sample, meaning we define a population and every individual within that population has an equal chance of being selected to be a part of our study, that would provide us with what's called a representative sample, theoretically. A representative sample gives us a sample that is a very accurate snapshot of what the population looks like. and it provides protections against bias. So again, if I try to generalize the results from a VA study to the United States population, there could potentially be bias in that the age distribution is different, or the gender distribution is different, or maybe even the disease characteristics or features are different than what we would see in a larger population. But assuming that the sample is representative, the idea behind this is the summary statistics that we calculate. The sample mean, for instance, should be pretty similar to the actual mean of the population that we're investigating. The variance, or the standard deviation of that outcome in the sample, could be reflective of how variable this trait or feature is in the larger population. So there's some measure of accuracy linked to the summary statistics from a random sample that would not be linked to the summary statistics generated from a convenience sample, for instance. And of course, this is also the goodness, in quotes, of these summary statistics, or this information that you draw from a sample, is also tied not to just how you're sampling them, but how much of that population you're sampling. So if I only take 10 observations from a population of 100,000, I'm not likely to get very accurate information, because the chances of me getting a representative sample when I'm only looking at 10 people are very small. And again, the key is making sure that you're actually sampling from the population of interest, understanding what your population is. Random assignment is another name for randomization. So it's how we assign treatment to subjects on our study. Random assignment, or randomization, ensures some control over what's called nuisance variation. So if you remember back last week at the very beginning, we had an example around a workplace toxin, and how that workplace toxin could or could not be linked to problems getting pregnant in women. In that study, randomization was not used, so we ended up with this nuisance variable, which was exposure to smoking through the previous generation, that could also impact the ability of a woman to get pregnant. Nuisance variables are any undesired sources of variation in the outcome. And these nuisance variables can either systematically distort the outcome in a particular direction, which was an example that I gave, where suppose that if a woman smokes, then while she's pregnant, she is causing problems with her fetus, her female fetus, for the future, in the form of having prolonged time to conception for that future mother, generation down. That's kind of difficult to describe. But anyway, the bias comes in a systematic distortion of the outcome from a nuisance or a confounding factor. You could also get nuisance variation in the form of increased variability in your outcome. So this happens when there's some other source of variation, but it's not systematically distorting results in one direction or another. It's just increasing the variability in your outcome, so it creates an issue with power of your test, because it's very difficult to see a signal when you have a lot of noise. So being able to limit those nuisance variables, either because of their potential to cause bias or to cause noise, can increase not only the accuracy of your conclusions, but also the power of your test to detect real trends in the data. But the idea behind randomization is that when we use it, when we randomly assign treatments to subjects, we increase the chances that all other factors that may contribute to changes in a response are distributed equally among the experimental groups. So the idea here is that when you compare Group A to Group B, Group A and Group B are identical with respect to anything that could cause a variation in the outcome except the experimental condition of interest. So if I see differences between Group A and Group B, their gender is the same, or the distribution of gender is the same. Their ages are the same. Their BMI is the same. Their level of activity is the same. The only way that they're different, other than some things that we can't control for, is the perhaps, let's say we're doing a weight loss intervention, the supplement that I'm giving them to induce weight loss. So if I see a difference in weight loss between group A and group B, I'm pretty confident that I can attribute that to the supplement that I'm giving them as opposed to any other feature that may cause weight loss to change. The key here, though, is that randomization, just like with random sampling, can fail in small studies. So just like with random sampling, if I'm only taking a snapshot that is a small fraction of a population, that snapshot could be very biased. I may just by random chance get all 10 people who are going to respond poorly to my intervention because the population is so large and the random sampling didn't work. Randomization is the same way. If I know that gender could cause variation in my outcome, and I only have a total sample size of 10, I randomize 5 of them to treatment A and 5 of them to treatment B. There's actually a pretty good chance that I could get a majority of males in one group and a majority of females in another group because my sample size is too small. So randomization only really works when you have large studies. And when I say large, there's no magical cutoff. That's why very often whenever you see the results reported back to you from an analysis, you get that table 1 if you have groups that you're comparing. Table 1 includes all of the different baseline features or characteristics of your sample and then a visualization of them between the two groups, treatment A and treatment B. So you can see, are there any obvious imbalances here, at least among the things that I know could be nuisance variables. And that's often reported in small studies along with p-values where you're actually testing, are these things imbalanced between the groups? And your p-value would say, yes, you have a problem with BMI. BMI is much higher in group A than it is in group B. Randomization failed for that factor. In larger studies, there really is, well, again, art and science here. Depending on who you talk to, some people will say you always test and get p-values to make sure that your randomization works. Some people will say there's no need to because you have a large study and randomization theoretically should work. So sometimes you'll see actual inferences reported for those table 1s and sometimes you won't. Another way that we try to minimize the impact of bias to increase the validity of our results are through control groups. There are many variations on the type of control that you can include in a study, but I'm going to talk about probably the 3 most common here. The first being what's called a null control or a negative control. And this is generalizable to any kind of experiment, but specifically in clinical trials, a negative control is a set of concurrently observed patients who receive no treatment. You just observe them, observe how their condition changes over time. So these negative conditions or null conditions are conditions under which you really wouldn't expect a change in response. Or if you see a change in response, you can attribute it to a natural progression of the disease or the ailment. So it may get worse or it may get better over time, just as a function of the disease itself. These kinds of controls allow us to measure what changes, if any, we would observe simply by observing the subjects. An example of a negative control, of course these are not always ethical or feasible, but you can have a study of migraines where you have a small control group of migraine sufferers that you just observe in the same way that you would observe your treated group of migraine sufferers to see where their migraines, how their migraines progress over that same period of time. Some sufferers may see some relief in symptoms simply due to the passage of time. The ailments tend to resolve at some point on their own. So if you didn't have a negative control in this case and you saw resolution of symptoms with a therapy, the resolution of symptoms could either be to the actual treatment that you're giving the migraine sufferers, or it could just be because their migraines went away. Without a negative control, you wouldn't know whether it was due to the treatment or due to just the natural progression of the disease. Positive controls or active controls are another type of control group that are very common in clinical trials. These conditions, these types of control groups are given experimental conditions under which you would expect to see changes in their outcome. The purpose of a positive condition is to allow us to measure the validity of our experiment. In other words, since we know what to expect for patients with a particular type of cancer when they get a particular type of chemotherapy, if we include a control group, a positive control or an active control of those patients with that chemotherapy and don't observe what we would expect to observe, then that may trigger us to examine our experiment. We may have the wrong patients. We may not be giving it in the right way. They may be doing or have other therapies that they're taking that are reducing the effectiveness of the chemo. So the idea here is to allow us to see that our experimental conditions, our experiment is set up appropriately, that we have the appropriate population with the appropriate conditions to elicit the expected response. If we don't, then we may want to take a step back and try to figure out why we're getting a response different than what we would expect. And so, of course, the example that I give here is an existing chemotherapy is included in a clinical trial of a new chemotherapy. If subjects who get the well-known existing chemotherapy don't respond as expected, it may be that there's something wrong with our experiment. And it might be easy to find, identify, it may not be. Another reason for using these positive conditions or active controls is for ethical reasons. You would never want a control group where you withhold the standard of care. So this is very often the standard of care for the study. And then, of course, placebo controls. Placebo controls are any controls that are considered sham conditions. These sham conditions potentially produce real responses in patients, so they're measuring the power of suggestion. An example of a placebo control is on a study where you're treating anxiety through some kind of pill form medication. You have an experimental group of interest where you're giving them your pill that has the active anti-anxiety med in it, and then you have a placebo control where you have a pill that looks identical and tastes identical to the true pill, if you will, but it has no active ingredients. There's nothing in it that should really be causing a change in these patients' anxiety levels. So if you have a placebo control and you see a change in their anxiety levels, you know that these individuals, or at least this condition, is modifiable to some degree by the power of suggestion. I'm going to the doctor. I'm actively addressing this problem that I have. Therefore, my anxiety levels automatically don't go down a little bit, at least during the period of time that they're observing me. If you were to be giving a pill for that's anti-anxiety and it induces a change, but you didn't have a placebo control, you would not know whether it was just the act of being treated and observed that shifted anxiety levels lower, or if it was the actual active ingredient in the pill. So again, the placebo effect is a very well-known effect that's been studied for a long time. The problem with placebo controls is that sometimes they are unethical. I teach a course in clinical trials where we always talk about sham surgeries. There are actual experiments where, for instance, on knee, I don't know if it was knee replacement or not, but there was some kind of a surgical intervention, and they had a sham surgical control group where they went in and they opened up the knee and then they closed it. And obviously the surgeon knew whether or not they did the actual surgery, but the patient did not. I would say that that's probably very hard to get through human subjects. And then, of course, the third way that we can improve the validity of our findings is through blinding. Blinding, again, all of these things, randomization, controls, and blinding are not always feasible. They're not always appropriate, they're not always ethical, but when they are, they should be used. Blinding simply removes the knowledge of the treatment, the experimental condition, from the subject who's being treated. That's what's called single blinding. You could also remove the knowledge of the treatment from both the subject who's being treated and the person who is collecting the subject's response to treatment. So if you're doing some kind of a clinical evaluation, you're giving you're asking them about their pain or some kind of quality of life, it would be nice to not have knowledge of what condition they got, because your own inherent biases could impact how you interact with the patient and how you measure their response to treatment. And then there's another, probably less common approach to blinding where the statistician is blinded as well. This is called triple blinding. So as a statistician, if I'm blinded to treatment, then I get the data where the treatment condition that each patient got is just, it's like a dummy variable. I don't know which is which. So it may be A and B, but I don't know what A means or what B means. And the purpose of that is to, again, just remove the knowledge of the treatment condition from the statistician, because we provide a service to you by doing the analysis. We want to make you happy. And if you want that statistically significant result in one direction or another, we feel that and it may bias how we approach an analysis plan. If we didn't find it or it's really close, how could I make this more powerful? Or should I have done this other test instead? So it removes the knowledge of which condition we're looking at and allows us to use our scientific training, our statistical training, to drive all of our decision making when it comes to which methods to use and how to apply them appropriately. So we don't let our own bias as your collaborator influence how we do an analysis. The things to consider whenever you're designing a study and doing an analysis and interpreting the results of a study, and you can actually also take these different questions with you whenever you're reviewing the literature. Does the design that you've chosen or that the people chose for their study actually permit a calculation of a valid estimate of the treatment effect? Are they actually testing what they think they're testing, or are they potentially estimating changes that could be attributed to something other than the treatment of interest? Does the data collection procedure produce reliable results? What we mean by that is maybe there are biases that could be induced into your outcome measure based on how the outcome is collected. If you're using a blood pressure cuff and you're using two different blood pressure cuffs and one's not calibrated correctly, or if you have two different nurses who are collecting some measurement from your patients, from your subjects, and one nurse is more trained, has lots and lots of experience, and the other one is not as well trained and maybe has a lot more noise or measurement error in their results. That could affect the reliability of the results simply because the data is being collected with some kind of error associated with it. Do you have power to actually test the hypothesis? This is a consideration that you should always ask yourself when you not only have done the analysis for your study, but when you're reading the literature. If you find that they have a statistically insignificant result, that statistically insignificant result could either be it could be a correct decision and that there really is no difference or no change or no association between what they're looking at. Or it could be that they just didn't have enough data to detect it. And that, of course, requires just kind of looking through and making sure, was this a small study? What's the variability? What's the actual effect that they observed? Did they see a really large effect, but perhaps they didn't have enough data to flag it as statistically significant? Is the design efficient? So this is more when you're truly designing a study. When you have an efficient design, it's the design that requires the fewest resources, either through time or number of subjects or even cost, that will actually give you a valid estimate of the treatment effect. Statistics, experimental design is an art and a science, so there's some level of subjectivity whenever we get to a point where we've limited or minimized or got narrowed down our options. Oh, I thought I had a... At some point, it could be that the sample size required for the competing designs is the final say. This one requires 150 subjects. This one only requires 100. I'm going to go with the one that has the maximum efficiency under the constraints imposed by my experiment. And then, of course, you always want to be able to give an apples-to-apples comparison of your findings with findings that have been produced in the past by other researchers in your area. So make sure that you're using accepted practices and procedures used in your research area, especially when they're valid. If everyone is measuring response to this treatment that you're looking at in a certain way, meaning they're using a particular measurement as opposed to this other measurement, this other tool, then even if you feel like this other tool is better, you should be collecting the tool that everybody else is collecting, so you can at least show them, by the way that you're doing it, this is our result, and the way that we think we should be doing it, this is the result. So make sure that you have provided enough information that people can do comparisons between what you have found and what's been found in the past. I'm going to pause here and just make sure that I don't have a question. Okay, Lauren asked, would you include a positive and negative control in a study? And Lauren, the answer is you could, if you need information from both. So the negative control, again, is just to see if you don't have good, reliable information on how, whatever it is you're after, if it's migraines, for instance, if you don't know how these things resolve on their own or how they progress on their own, untreated in the population you're studying, then you need to collect that information in a negative control group if it's ethical. If there is also an active standard of care, you could include that as an active comparator in your study, and I would say if there's a standard of care, you may have some issues ethically with also including a negative control, because if there's a standard of care, generally you don't want to withhold that from patients in a study. Does that answer your question? Perfect. Okay. So different study designs. There are many variations on designs that can be applied in clinical trials. I'm going to focus on probably some of the most common that are at least reported in the literature. I showed this graph last week and said that we would discuss these things more specifically this week. So I will define a few of these study designs that are being reported in the literature, just so you can differentiate between what is a case control study versus a cohort study. What are usually, in most cases, the differences between studies that are approached in these ways, and what are the limitations and strengths of each. Again, the ones on the left here are primarily descriptive. Their purpose is really just to describe interesting findings. You're probably not doing a lot of hypothesis testing in these studies, or if you are framing that in terms of the results being hypothesis generating. So if I did an analysis in a cross-sectional study where I found an association between blood pressure and different types of blood pressure medicines, or maybe some potential bad outcome, some kind of cardiovascular outcome and blood pressure, different types of blood pressure medicines, those would have to be framed as hypothesis generating. I found evidence that there's an association that needs to be investigated in a more rigorously controlled experimental situation. So as you go from left to right, not only are you increasing the complexity of the study through the way that you try to impose constraints on the study design through either randomization or control groups or blinding and increasing sample size, you're also increasing the confidence that you have in the results that are produced. That randomized controlled trial, the RCT there on the right, is the gold standard of evidence for clinical studies, but it's not always a feasible option for studies. So let's begin here with a cross-sectional study. A cross-sectional study is a snapshot in time. There's no time component to a cross-sectional study. Cross-sectional studies are really just designed to investigate associations between various features in a population. And I'm giving it here and I will for the remainder of the lecture today talk about this in terms of an exposure of interest and a disease of interest, just to keep it simple. There are many variations on the types of variables that you could be looking at, but really in cross-sectional studies, we have some exposure or some independent variable and some dependent variable that we're interested in, and we just want to know how are they associated. When we select our study subjects, we're really sampling from a population based on both their exposure status, so what is their independent variable of interest, and their outcome status. What is their disease outcome? Are they healthy? Are they diseased? And since we don't really have valid information about which came first, the exposure or the outcome, we have no direction of inquiry. We can't say X followed Y or Y followed X, only that we tend to see these two things together more frequently than not. Here is a graph. What you'll see in a few slides when we get to a case control study, for instance, when there is a time component, then I will reflect time on the x-axis, if you will, of these. But notice that in the cross-sectional study, we don't have any time component. We just have data available to us on these patients or these subjects in terms of both their exposure and their outcome, and we try to see how is exposure associated with disease. How is not being exposed associated with disease, and are these two things different, to give us an idea of whether there could potentially be some associations here. The limitations of a cross-sectional study include the fact that we can't obviously determine cause and effect simply because there are too many potential sources of bias here, too many confounders. In addition to that, I guess probably before that, we really can't determine any temporal relationship between the exposure and outcome because we're looking at information as a snapshot in time, and we don't have reliable information about which came first in our sample, the exposure or the outcome. The types of statements that we can make with cross-sectional studies are much more ambiguous, I guess you would say, than something that actually has either a temporal component to it or more controls for bias. We can say that exposure is associated with disease, but we cannot say that it causes the disease or that the disease necessarily follows the exposure. There is an example that I pulled from the literature, and I pulled this because this is an example that's used in some common experimental design textbooks of looking at the association between fluoride supplementation and cavities in children. And this is the Newberg-Kingston, it actually is called the Caries fluorine study, but they're studying fluoride. They're trying to determine the extent to which sodium fluoride supplementation in the drinking water is associated with reduced cavities in children. So there are two different groups that we have here. One is exposed to the supplement, which is a positive in this case, the city of Newburgh, versus one that is comparable in terms of its population, but unexposed through the drinking water to fluoride. And one of the outcomes that they look at is the cavity-free rate in the erupted first permanent molars based on clinical examination. So they randomly sample children of various ages in these two cities, and they give them a clinical examination to determine on their permanent molars, their first permanent molars, are they cavity-free or not. So this analysis, this cross-sectional study, has data that comes to us in the form of a contingency table. This contingency table data is very common when we're looking at the association, whether it be simple association or cause and effect association, between a categorical endpoint and another categorical endpoint. They have an idea that fluoride could cause reduction in cavities when exposed in at certain ages to the drinking water, but they're just collecting preliminary evidence on this right now. So they've classified about 1,700 children into one of four groups. Notice how these four groups correspond to this graphic. We're just gathering data on their exposure, which city they grew up in, and the clinical exam of whether or not they have a cavity or more cavities on their molars. And then they classify them into one of four groups: exposure and cavities, exposed to fluoride, no cavities, not exposed, cavities, not exposed, no cavities. The types of summary statistics that we can report for cross-sectional data include things like prevalence of cavities in the exposed versus non-exposed group. So let's look at the notation. Don't get bogged down by the plus signs. All this is saying in English is, what's the probability of having a cavity given you were exposed to fluoride? So the plus corresponds to, yes, we have cavity. The plus here corresponds to, yes, we were exposed to fluoride. And this is simple if you think back to your first week of your introductory stats course. It's just a proportion. We first limit our denominator to this population who was exposed. So the exposure is right here. There were 734 children in our study who were exposed to fluoride through the drinking water. So that's the denominator. What proportion of them ended up on clinical examination having a cavity? And that's the 174. Here's their cavity status. So taking that and dividing tells us that the probability or the proportion of children with cavities who were exposed to fluoride in the drinking water is about 23.7%. We can compute a similar probability for those who were unexposed, and that would be through this row. This is the exposure variable. 940 were unexposed. Of that 940, 501 showed evidence of cavities in their molars on clinical examination. So when we do that division, we end up with 53.3%. So the chances of having cavities is actually higher when you're not exposed to fluoride than when you are. Does everyone see that? That's just the interpretation. So it looks like there is some association between exposure to fluoride and cavity status. We could also, since there's no temporal component here, we don't know chicken and egg kind of thing, the limitations of the data tell us we aren't necessarily confident that the exposure and the cavities occurred in some particular timing. We have an idea, but we're not confident in it. So we can also look at, among those who have cavities, how many or what rate of them were exposed to fluoride, versus those who don't have cavities, what was the rate of fluoride exposure? And that's computed by looking at, oh, I have a typo here. I'm so sorry. copy and paste error. So let's work through this. So what we do is we first limit our findings to the disease. What is the probability of being exposed given we have cavities? So that this part defines our denominator. That should be 675. That's what happens when you copy and paste and forget to change a number. So this denominator should be 675 here. Of those 675 children who have cavities, how many were also exposed to fluoride? And that's 174 out of 675. Somebody want to do that in their head real fast? Let's see what that percent is. 174 divided by 675 is about 25.7%. Versus, I believe this is correct. Yeah, this is correct. Among those who have no evidence of cavities, how many of them were actually exposed to fluoride? So that is this column. Among those who don't have cavities, how many were exposed to fluorides? That's 550 out of 989, which is 55.6%. So again, 25.8% here versus 55.6% tells us a little bit about how prevalent exposure was in those with the condition versus those without. If we were going to do an analysis, a formal inferential test of association, which we will do next week, we would do what's called a chi-square test. And a chi-square test simply says cavity status and exposure to fluoride are associated with one another, meaning that the cavity status is the rate of cavities is higher or lower depending on your exposure to fluoride versus they're independent, meaning that we really see no impact on whether or not a child has cavities based on whether or not they were exposed to fluoride. That's called a chi-square test of independence. Case control studies are a little bit more complex than the cross-sectional studies because we now have a temporal component. Now this is not always true. There are variations on case control, but if you look at the name of case control, that will be the first indicator of what you're selecting your study subjects based on. You're selecting them based on whether or not they have the disease or not, and then you're looking backward in time, retrospectively, to see whether or not they have the exposure of interest or not. So these types of studies are designed, again, to test for association between a disease that we know has occurred or not and some past exposure of interest. And then they're classified usually as retrospective because we're looking backward in time. And when we select our study subjects, when we determine who's in our study and who's not, we do it based on whether or not they have the disease. Very often, we have a set of cases, a set of sick individuals, and we want to select a similar group of controls that are healthy. In other words, they have the similar demographic and clinical characteristics to our cases, yet they don't have the condition. They don't have the disease or whatever the outcome is. If we look at the kind of the flow here of a case control study, we define our population, we gather information on their disease. Again, usually we have in hand cases, sick individuals with a condition. We gather a similar control group where the only way that they're really truly different is their disease status, and then we either ask them, have patients self-report, or we look at their medical records, their charts, to look to see what the exposure, if you will, the exposure status is of this person. So this is common. Think about this in terms of lung cancer. So we have individuals with and without lung cancer. We look back in time to see what their different risk behaviors were. Did they smoke? Were they exposed to something in the workplace that could potentially cause lung cancer? And so our direction of inquiry is backward. The limitations of case control studies include the fact that we, again, can't determine cause and effect simply because we're only gathering data on their disease. There's no randomization here to minimize the impact of other potential factors that could be causing variation in our outcome aside from the exposure status. So there's no cause and effect here, only association. Unlike the cross-sectional study, though, now, since we have a temporal component, we know what occurred first and then something else occurred, we know the temporal relationship between exposure and outcome, if there is one. Retrospective studies have issues. Anytime you look back in time, you're dependent upon the amount of data you have access to. You're also dependent upon the quality of data that you have access to. So if you're using historical records, for any of you who've ever done retrospective studies using patient medical records, there's a lot of limitations that you can, just based on data collection and data accuracy. Or if you're asking the individual subject what their behavior was, I know for me, sometimes I can't even remember what I did yesterday, let alone 10 years ago, to be able to tell someone a valid representation of my risk or my exposure. So depending on data, on things and events that have already occurred in the past and may or may not be recorded correctly, can obviously give you a biased result in your study. One of the strengths of retrospective or case control studies is that they're good for studying rare diseases, rare events, or when there's a long time interval between someone having the behavior or the exposure or the risk factor and then the ultimate disease outcome. And if you think about that, it makes sense by looking at this graphic. If you have a rare disease, then you can actually go out and solicit those individuals with that condition to be in your study and then gather a similar group of controls, of healthy controls, and then look to see how they were different in the past. What are their different genetic components? What are the different risk factors or behaviors or environmental conditions that could have potentially caused this condition? If there are only 20 people in the entire nation with this condition, it would be nice to have all 20 on your study. There's no way that you could get a valid experiment done to address a question about a rare disease if you just randomly sample from people who are potentially at risk and then wait. If the prevalence of this condition is so small, you may end up waiting 10 or 15 or 20 years to even get one of these people to come down with a condition. So again, case control studies are ideal when there are rare events that you're studying, rare conditions that you're studying, or when you have long time intervals between exposure and outcome. Here's an example of looking at cervical cancer and smoking from 1982. The investigators were looking at the relationship between prior cigarette smoking behaviors and cancer of the cervix. They had 181 cases, 181 individuals who were sick, and they had 905 healthy controls, and then they interviewed them to ask them about their smoking history. Have you ever smoked? Have you never smoked? If you're a current smoker, what are your current smoking behavior? What was your smoking behavior in the past? And what they ended up finding was that a much larger proportion of the cases than the controls had smoked cigarettes. I'm not reporting the real data from that study because they actually had it partitioned out by many, many other factors. But let's look at an example set of data that could be addressing the same question. We have 200 subjects in our study, 100 cases of cervical cancer, 100 controls, healthy controls. And then we ask them about their smoking behaviors. We're going to classify them as having never smoked, which is the negative. So 180 of our 200 subjects had never smoked. Only 20 of them have ever smoked. And it turns out of the 100 that had cervical cancer, 15 of them had smoked in the past. Of the 100 that were healthy, only 5 of them had ever smoked in the past. So it gives us an idea of, in terms of the healthy controls, potentially what is the rate of this condition among those without the risky behavior or the risk factor. When you when you apply the exposure through smoking, it gives you an idea of whether or not that risk increases or decreases. So very often you'll see something like an odds ratio reported for data like this. It looks just like the cross-sectional study, but now we have sampled from this population in a way to try to make our cervical cancer cases and our healthy controls as similar as possible on everything except for the disease, and to look back at risk factors. So when we're reporting the odds ratio, the way that you compute it, it's the ratio of the odds of exposure in our cases to the odds of exposure in our controls. And the odds is just a fraction. Odds came about from gambling. So it's like 3 to 1 odds, 4 to 1 odds. It usually comes in integer values. And it's simply the ratio of the number with the exposure to the number without the exposure within the diseased or the healthy group. So 15 out of 85 over 5 out of 95. So this is the proportion with the exposure who ended up being diagnosed with cervical cancer, and this is the proportion with the exposure without the exposure who ended up being diagnosed with cervical cancer. And so it gives you ratio-wise what's the increased probability or the increased risk of developing the condition if you have the exposure. So when we see an odds ratio of 3.4, an odds ratio of 1 would indicate that there's an equal chance, right? An equal chance of developing the condition of cervical cancer whether or not you've smoked in the past. But when you see an odds ratio greater than 1, that tells us something about the increased risk that could come about with the exposure. And again, it just, in this case, indicates an association. There's no cause and effect here yet because we haven't been able to put into place many of the things that would minimize the impact of other nuisance variables that could cause increased chances of cervical cancer in these patients. For instance, it may not be their smoking status, it may be their level of activity that's causing increased risk of cervical cancer. It could be that those who smoke are also more sedentary, so it's their sedentary behavior, not their smoking. Again, this is all a contrived example, but it shows you that sometimes risky behaviors come together in individuals to produce a result that can't be attributed to one alone. But the interpretation here is that the odds of exposure in those that are diseased is actually almost 3.5 times that of those who were healthy. Cohort studies are similar to case control studies, except they are looking forward in time generally. What we do is we select our study subjects. This is probably one that's most similar to what's called a randomized controlled trial, in that you're observing your independent variable and you're following subjects forward in time to see whether or not they end up with the disease. So your study subjects are selected based on whether or not they have a risky behavior or an exposure status, and then you follow them in time to see whether or not they end up having the condition of interest. This is what's called a prospective study. So again, if you remember from the previous slides, a few slides back, time was up here and we looked backward. Well, now time is back here and we look forward for cohort studies. We define our population. We gather information on their exposure status. Yes, they smoked. No, they didn't. And then we follow them in time to see whether or not they eventually develop the disease or whatever their outcome ends up being. This could also be, if we get outside of this sort of epi framework of study design, this could be the type of treatment that they were actually given. Let's think about this in terms of cancer. We have individuals who have cancer A. Some of them were treated with drug B, some were treated with drug D. And we're just interested now, there was a lot of clinical decision making that went into deciding what treatment to give those who got drug B and those who got drug D that we really don't have information on here, but we're interested in how did they respond to that particular treatment that they were given. If we see a difference in their response, we don't know if that difference is attributed to the difference in the drugs. In this case, drug D may or may not be more effective than drug B. It could be the clinical decision making that went into putting someone on drug B over drug D. Maybe individuals who are given drug B are much more sick, and that could be the reason why their outcomes are different. So that's one of the issues, again, with these observational studies, is the fact if you're not randomly assigning or exerting that kind of control over their treatment, then it could be some other factor that's causing differences in response than what is actually under investigation. But here, this could be their treatment and their ultimate outcome, either resolution of the disease, it could be their survival, it could be whether or not they develop a disease later, but you're following them forward in time. The limitations of these cohort studies are the same limitations that you would have in any prospective study. If you get 100 subjects on day one and they agree to participate in your study, some of them will not participate all the way to the end. So you'll have missing data potentially on whether or not they ended up having a resolution of their disease or whether they ended up with the disease or the outcome of interest. So that's what's called attrition or loss to follow-up. And that's a limitation of a randomized controlled trial, any kind of longitudinal study. In fact, the longer you follow them and the more frequently you follow them, usually the higher this number tends to be. When you have prospective studies, they cost time and money, and they're very inefficient when you have rare outcomes, for the same reason why retrospective studies are good for rare outcomes, because if you have to follow individuals for 20 years before they develop a condition, you may have spent 20 years of your life following and doing a study that at the end you actually can't answer the question to because you didn't have enough people have the event, have the outcome. The problems with bias are all of those that are associated with not only non-randomized observational studies that, like we spoke about on the last page, but also non-response. Either having patients just quit coming back to check in and so you can record their status, or deciding that they didn't want to be on the study anymore and withdrawing. An example of this is the Framingham study, where they're attempting to identify factors related to cardiovascular disease. This is just the initial look at this data set is out there and available. They have 5,000 people in Massachusetts who did not have clinical evidence of heart disease. They were followed at regular 2-year intervals for decades to see whether or not they eventually developed cardiovascular disease, so they could try to determine what are the potential risk factors for the eventual development of that disease. And they were able to identify from this study hypertension, elevated cholesterol, and cigarette smoking as being associated with the eventual development of cardiovascular disease. Again, observational, and there could have been other factors at play here that were either not identified or maybe potentially identified incorrectly because they were confounded with some other behavior or risk factor. But this is one very common example of that cohort study. Analysis of cohort data, again, you have your groups. This is an example of a contingency table type of analysis, and very often you report things like relative risks or odds ratios. I'm going to actually just kind of skim over this because I didn't provide real data for it, and I think most of us, we've seen the contingency table up to this point, so we understand what each of these are doing. But cohort data, again, any of these studies don't necessarily have to have measurements that are, yes, they had the disease, no, they didn't. Yes, they ended up having the exposure, no, they didn't. You could have any variety of types of measurements. In the end, what you're looking for are associations between them or differences between them, and the limitation is whether or not you can say one occurred before the other, one is associated with the other, or one is caused by the other. And in all of these observational studies, there's no cause and effect link, and only in some of them are there temporal components. Cross-sectional studies are a single snapshot in time, so you can't determine that X preceded Y or Y followed X. And the case control and the cohort study have their own limitations in terms of what are the problems with looking backward in time versus what are the problems in looking forward in time. Which leads us to the gold standard of studies, the randomized controlled trial. Randomized controlled trials are designed to attest for associations between an intervention or an exposure and an ultimate outcome, whether it could be the development of a disease, it could be the resolution of a disease, it could be the length someone survives with a condition after getting a certain treatment. The selection of your study subjects is based on their assigned exposure status. So I'm going to randomly select subjects and assign them to treatment A or treatment B, or exposure A or exposure B, and follow them forward in time to see what their eventual outcome of interest ends up being. This looks an awful lot like the cohort study, only now we exert control over their exposure. We randomize them to either be exposed to the treatment, or in the case of a very simple trial where they have either an untreated control or a placebo control, to not be exposed to the treatment of interest. So we're exerting some control here to minimize bias by not letting patients or subjects self-select into their exposure status, and we're not allowing a clinician to say, I want that person on that treatment and that person on that treatment. Because if we're allowing clinical decision making to go into treatment versus control, then we are biasing the ultimate comparison of outcomes for treatment and control, because we also have, for instance, maybe sicker patients on one therapy than the other. This is an example of that. Suppose we want to compare surgery for a condition to a drug that's also designed to treat that condition. We know that major heart surgery that we're investigating is invasive and complex, and in fact, some people will die due to the surgery rather than the condition. So if we're having some kind of clinical input into how patients are assigned to treatments, we may, on purpose or not, assign patients with less severe disease to the surgery group because we think their chances of surviving the surgery are higher. So the question here is, if we have two groups, one with the surgery, one with the drug, where the two groups are also different in terms of their disease severity, when we see a difference in their survival at the end of the study, is that difference due to the surgery versus the drug, or is the difference due to their disease status, less severe disease versus more severe disease? And the answer is there's no way to know if you do a study like this. The study would be inconclusive. It would unfortunately be a waste of time, money, and patience. Does everyone understand why? You have what's called confounded the treatment effect with disease. Disease could impart some kind of benefit in terms of less severe disease having prolonged survival. That is confounded with any benefit that you might have seen depending on which of those was more effective or not. So to fix that, we would have to randomize. Of course, a lot of considerations have to be taken before you decide to do randomization. You have to first make sure that it's ethical and that it's feasible. If it is both ethical and feasible, then it's critical to use, because there's no way that you could be aware of all possible confounders that could result in prolonged survival after treatment for coronary artery disease. Observational studies like the cross-sectional study, the case control study, the cohort study, have little to no formal control for any confounders other than the way we sample. So we can sample our subjects in a way that our cases are as similar as possible to our controls. But beyond that, We really have no other controls for what's called selection bias in this case. So regardless, in those observational studies, we can't conclude cause and effect based on their results. Randomization and random sampling forms the basis of inference, which leads us into quality of evidence. And this very funny, I think funny, sadly funny, what do you call this, cartoon from the Cincinnati Enquirer. I've seen it actually in many different presentations over time. Today's random medical news from the New England Journal of Panic-Inducing Gobbledygook. Sometimes it feels like we are spinning the little dial here to determine what causes what in who. And it's according to a report released today. So as a statistician, whenever I read studies, I understand very often the limitations. Sometimes I don't actually because they haven't given me enough information, but I at least as a scientist can see where maybe a study team has made a mistake to give conflicting evidence that, you know, has been maybe, oh, I'm trying to think of an example. The example that I give every year is I have kids. I have kids that range in age from 15 down to 7 months. So what I was told by my pediatrician with my first 15 years ago, in some cases is totally reversed now that I have a new 7-month-old. You know, sleep on their stomach, sleep on their back. Breast milk versus formula. I'm trying to think of all the different conflicting evidence that we've gotten. So sometimes it's easy to identify why evidence is conflicting and sometimes it's not. But the idea here is when we put out information, we need to also provide with that information the limitations of the context that generated that data. So people can understand why potentially we got something different than what has been shown in the past, or why we feel that what we have now is a better or more accurate representation of what the truth is than what was produced in the past because of the limitations of what was produced in the past. But again, I just think that it's funny because it's true. When you're trying to design a study and you're going out into the literature to see what's been done before, there may be conflicting evidence. In fact, there probably is conflicting evidence. And the question is why? Why is there conflicting evidence? There was a talk given by Gary Gronzith several years ago called The Way Physicians Think that I think can be applied to just about any science. And it's just acknowledging that there are principles that we're all trained in. There's evidence that we collect in various ways, and then there's a level of judgment on top of that. So again, the science and the art that leads to an ultimate decision, either by a scientific community to recommend, for instance, that mammograms only be performed so many times a year after a certain age, and then we change that the next year, or people argue over it. Or how do you treat a patient, just day-to-day basis? And the answer, again, is because there's no perfect research study. Every study has limitations and every study has context. Medicine and research is an art as well as a science, and unfortunately, we're getting better, but unfortunately, historically, the literature is full of poorly designed, poorly executed, and improperly interpreted studies. So it's up to us to critically evaluate their merit. There are different ways, different problems with published research findings. There's a guy, John, I'm going to guess his name is Ioannidis. I think he's got a Greek background, at least that's what it looks like, who does what's called meta-research, which is the research of research. I would encourage you to go out and watch some of his YouTube videos. He's done YouTube videos through the Center for Open Science. What he has built his name on is trying to figure out how to improve the validity of what we publish, of the research that we're undertaking. So he tries to identify sources of bias from, in this case, published research. So here's the reference at the bottom if you're interested in looking him up. But if you look up his name, you'll actually find many, many different publications over all the different problems with the literature. Publication bias is one that's known to exist. It's probably one of the bigger ones. I think we are getting better with it, though. Publication bias is the tendency for us as researchers to submit positive studies over negative ones. So if we're doing a study and we find a significant result, we got to get this out. If we're doing a study and we find a negative result, meaning we didn't find an association or a difference, maybe that paper gets put in our shared drive and we'll deal with that when we have time. Because it's going to be harder to publish, number one, because journals are less likely to take negative findings. But also, we've got to publish and get funding for studies that will hopefully produce positive results. So that's on both the researcher and the journal. That's journals, I think, are getting better, and I think us as researchers, we're getting better too. We also have a tendency to do what are called undersized studies, meaning we do a lot of small studies, and our progression through the science to larger and larger studies is not always as efficient as it could be. We also produce a lot of small effect sizes. We do a lot of multiplicity in our testing. What does multiplicity mean? Does anyone know? We do a lot of tests on a little bit of data, and we report potentially only the things that we found that were interesting, and we fail to report the things that we didn't find. There are a lot of hot topic areas, and there's a lot of variety and flexibility in designs, definitions, outcomes, and analytical modes. So there's a lot of reasons why we may have a distorted view of science as it currently stands, and that's really just attributed to our publication practices and some of the ways we go about designing and analyzing and reporting results of studies. I would encourage you to read this. I would also encourage you, there's been a huge discussion around hypothesis testing or significance testing, as it's sometimes called, and p-values. Has everyone kind of heard of this? I think it started in some kind of psychology journal a year or two ago where they said, keep your p-values. We don't want them. We don't want your hypothesis tests. You cannot publish in our journal if you do a significance test and report a p-value. You'll have to do some other thing. I think that's a little bit of an extreme approach to a problem that we know exists, which is the problem of p-values. The American Statistical Association, which is the international organization for statisticians, has actually issued a statement on p-values that's worth reading. I've linked to it here in the PowerPoint, and I think it's worded so anyone can understand it. But the idea here is that p-values alone can't confer the significance of a result. P-values are really supposed to be interpreted in the context of a very well-designed study. And if they're generated from something other than that, they alone really can't provide us with a measure of statistical significance, let alone clinical significance. But you have the link here to the actual publication by the American Statistical Association, and they talk about how the p-value was never intended to be a substitute for scientific reasoning. Well-reasoned statistical arguments contain much more than the value of a single number and whether that number exceeds an arbitrary threshold. The ASA statement is intended to steer research into a post-p less than 0.05 error. We'll see how quickly we can do that. I'm not sure that we're going to move away from it at any point. I'm not sure that we really need to move away from it, but I think as long as we can understand the limitations of the p-value, then we can do a better job of using it to help us make decisions. We'll get into p-values more when we get more into hypothesis testing. When you're evaluating an article, there are ways of looking at its validity and relevance. You can first determine the quality of the journal that the publication came from, that it was submitted to and ultimately accepted from. Some journals have a much more rigorous peer review process than others. Some, unfortunately, there's been a lot, again, in the news about journals that have popped up without peer review or with fake peer review. So that's been a major issue. So understanding the journal and the journal's quality gives you an idea of the validity and relevance of the result that's being published. You have to also look at where the study was done. How does the location reflect the larger context of the population? Oops. Does the sample reflect the targeted population? Are there any conflicts of interest that you can tell? Is the study sponsored by an organization that may influence the design of the study or the results? And then, of course, look at the intervention itself. Is it feasible, number one? An intervention that works really well is only as useful as it is available. So if it's not feasible or available, then it may not be a relevant result. You also have to look at the intent of the study. Is the intent of the study to produce a therapy? Studies that are looking at therapies are testing for the efficacy of drug treatments or surgical procedures or alternative methods of delivery. These are usually randomized controlled trials. If it's looking for a better diagnostic test, these are usually from cross-sectional surveys. They're trying to demonstrate whether a new diagnostic test is valid by comparing its ability to measure a disease or a condition to what's called a gold standard. And then there, of course, are screening tests, which are also cross-sectional, screening studies, which are used to demonstrate the value of tests which can be applied to large populations and can pick up diseases at a pre-symptomatic stage. These are usually done with cross-sectional surveys as well. Prognosis studies are used to determine what's likely to happen to someone whose disease is picked up at an early stage. And then, of course, causation studies are used to determine whether a harmful agent is associated with the development of an illness. I don't like this term because you're saying association, but you're calling it a causation study, but the idea here is that you're getting preliminary evidence of cause and effect. So your validity is also based on the intent of the study. Therapy, diagnosis, screening, prognosis, or causation. Look at the study design. Is the study design appropriate and optimal for what the study is intending to do? Are all the participants who entered the trial accounted for in the conclusion? I should pause here and make sure that everyone has at least heard of the Consort guidelines. Is there anyone here who has not heard of Consort? Someone tell me what Consort is, since you've all heard of it. Consort guidelines are they're a set of guidelines for reporting the results of clinical trials in order to support what's called reproducible research. So if you report the results of your study according to these nice guidelines, then you're doing a really good job of being transparent. You're doing a really good job of providing enough information to other investigators who maybe want to reproduce your study. They want to replicate your study and try to reproduce your results. The whole idea is to be transparent, to provide reproducible studies. Part of Consort guidelines include that nice, everyone, if you've seen the New England Journal of Medicine, the nice flow chart of the patient. This is how many were screened. This is how many were enrolled. This is how many were treated. This is how many we actually assessed the outcome on. And then if we lost people, how did we lose them and why? That gives you an idea of the validity of the results, because if you lost 50% of one treatment group, you may end up having a biased result. What protections against bias were put into place? Did they incorporate blinding, any control groups, or randomization? Part of the Consort guidelines requires you to state in the title of your study, this was a non-randomized something, something, something. So if you randomized, the term randomized has to be in the title. If you had a control, that has to be in the title. If you blinded, it has to be in the title. Table 1 provides you a comparison of how similar or dissimilar the groups you're comparing were at the start of the trial. Hopefully they were similar. That gives you an idea of whether or not the ultimate effect that they report is really attributed to the treatment or not. And then, of course, were the groups treated equally aside from the actual intervention? So The groups should be similar at the beginning of the study. They should be observed in a similar way, meaning with the same frequency over time. The only thing that should be different in the way a subject is treated on study is just the intervention that they receive. They should be followed up for adverse events in the same way. They should be followed up for the response in the same way. They should be treated equally in all respects aside from the actual intervention. If you're comparing two groups' adverse events rates, so how frequently are they having negative effects of some therapy, but you're following one group more closely than another, then you're likely to inflate the adverse event rate for that group relative to the other groups, simply because you're following them more frequently, so you're going to get more reports of adverse effects of treatment. If statistically significant, are the results meaningful? This gets to the p-value issue. Think about this not only when you're reading the literature, but when you're writing your own manuscript or when you're writing your own presentation of your study. You cannot simply provide p-values for statements where you say, yes, we saw this association, or yes, we saw this difference, p less than 0.01. That's not sufficient information for someone to critically evaluate the meaningfulness of your result. You need to also provide estimates, confidence intervals, effect sizes, something for someone to say that is an actual difference that's clinically meaningful as opposed to just being statistically significant. If you don't find anything, is it because there really was nothing there, or is it because your study was underpowered? You didn't have enough data for the test and the hypothesis that you were actually investigating. And then, of course, were there other factors not accounted for that could have affected the outcome? So you, as the author of a publication, can address all these questions. You can go out and find the consort guidelines or whatever guidelines are appropriate for reporting your study and adhere to those so other people can critically evaluate your results. If you're reading the literature, if you found a publication and they don't give you this information, that to me is usually the first flag, the first red flag that I don't know how good these results are, so I'm going to automatically assume the worst. If you can contact the author or write a letter to the editor of the publication or the journal, sometimes that will help improve the information that you get. But other than that, there's really not much that you can do with what's already been published. Common analysis methods. So this is leading into next week. We're going to end here with an example power calculation in RStudio, and then we'll get into different types of tests next week. So what are the different types of tests that we use? Well, we first ask ourselves, what's the research question? What kind of information is contained in the outcome? How many groups do I have? Am I analyzing a single group, looking for associations within a single group, or do I have multiple groups? Are those groups independent subjects, or are they somehow related? Are they repeated measurements on the same patient, or are they measurements on different patients? And then, of course, what's your sample size? Once you've answered these things, you have a good idea of the context of your data. You can narrow down the type of method that's appropriate. There are two different families of tests that are most often, that you often see in the literature. Sometimes you see parametric tests, which are things like t-tests and ANOVA, logistic linear regression. Those types of things are really designed for larger studies, big N, or maybe I should say big enough N, big enough sample size. Those tests were derived by someone using mathematics. So if you're familiar with, probably back whenever you first were introduced to algebra, you make an assumption about the scenario. Y is distributed normally with a mean of 0 and a standard deviation of 1. And then from there you use principles to develop a test statistic. The key here is, though, this is a mathematical proof. So if you haven't met the conditions necessary for the test, then at the end of that proof, whatever that mathematician or statistician derived is not or no longer what he intended it to be. So you can't do a parametric method on a small data set. Not necessarily because you haven't met the assumptions, but because you can't verify that you've met the assumptions. If I have a sample size of 10, it's going to be hard to verify that I've got approximate normality in those observations. I only have 10 observations. So parametric methods are usually only appropriate when you have enough data to assess their assumptions, like is the data normally distributed. Non-parametric methods are, I hate to say the word alternative because they're actually a really good and useful set of methods, but they are used when we have smaller data sets, smaller sample sizes where we really can't assess assumptions. These methods are more robust because they make no assumptions about what the data has to behave like. You can actually use these for really large samples as well. You can use the Mann-Whitney test in place of a t-test, for instance, when you can't meet the assumptions of the t-test, normality or equal variances. Mann-Whitney would be a good alternative to that because it's robust. It will give you valid conclusions when you have data that doesn't behave a certain way. These non-parametric or robust methods tend to strip the actual values off the data points and replace them with the rank order of the data. The only downside to a non-parametric test is that you tend to lose a little bit of power. So if I have data that's appropriate for the t-test, but I use Mann-Whitney instead, I may end up with a less powerful test of the effect. It's about a 5% reduction. The different types of tests that you can use if you're comparing categorical variables, look like a test of independence, you can use a Fisher's exact test or a chi-square test. The Fisher's exact test is a non-parametric test. If you're comparing two means from two independent groups, the parametric version is the two-sample t-test, a non-parametric version is the Mann-Whitney test. If you're comparing two time-to-event outcomes, you could use something like Cox regression, which has some assumptions associated with it. You could use the log rank test, which is a non-parametric test. This is actually the most common test for survival data. And then, of course, any comparison between two groups, depending on the outcome, can be adjusted for other things using some kind of appropriate regression model. If you have a yes-no outcome, a categorical outcome, you could use something like logistic regression. If you have a continuous outcome, it's like a change in blood pressure, you could do linear regression. If you had a time-to-event outcome, the Cox regression is most appropriate. I'm going to skip through. I always underestimate the amount of time. So I'm skipping through some information on if you're thinking about these clinical trials in terms of phases, what does a phase 0 study mean? What's a phase 1, 2, 3, and 4 study? So I'm going to skip through that and let you all read that on your own. If you're interested, the slides will be posted. I want to get to an example of the size of a clinical trial before we leave. That way we can make sure we get through it. So here, we have an example. The primary objective that we're looking at is whether or not a treatment can induce a change in some outcome. So let's assume our outcome is continuous, like HbA1c. And we have one treatment that's designed to lower HbA1c better than another treatment that already exists. So we have two groups. One is a control. I have placebo here. We'll stick with placebo. One is placebo, which should not induce any change, and one is an actual active treatment. We'll call treatment A. Our data analysis will result in the comparison of the mean response of subjects on treatment A to those who use the placebo. This is a common scenario that would result in us applying a two-sided, two-sample t-test at the 5% level of significance. And again, 5% level of significance has to do with our error rate. How frequently do we want to make an incorrect rejection of the null hypothesis? How frequently do I want to say there's a difference when in fact there isn't? And we don't want to say that very frequently, so we set that probability, that percentage, to be very small, usually around 5%. In order to power a study that requires a t-test to be performed on it, we have to know some things. We have to know, number one, what are the expected results under the control or under placebo? Well, we would expect under this control group to have the response be on average a 10. And then I have to think about, as a clinician, as a scientist, what difference would be clinically meaningful to me to observe in this study? If that difference is only a 1-unit difference, then that's what I should power my study to detect. If that difference is a 10-unit difference, then I should power my study to detect that. In this case, it would be clinically interesting to me to be able to detect a difference of about 10% in this outcome if it actually exists. If it doesn't exist, I don't want to flag it as statistically significant. If it's that or more, I want my test to tell me this is statistically significant. So this is part of the design process, trying to link the statistical significance to the clinical significance of the result. Here I have a couple of bullet points that kind of illustrate what I mean by linking the statistical significance to the meaningful difference if it exists. And sometimes it doesn't exist, so we shouldn't flag it. The power of the test is that probability that I will be able to detect this meaningful difference or something bigger than that if it actually exists. So when I set that power, a generally acceptable probability is about 0.8, so 80% power for the 5% type 1 error rate. Our hypothesis is that there is no difference in the outcome for the control and the treatment. That's mu1 is equal to mu2 versus what we're really after, which is some difference. If there's a difference equivalent to a 1-unit shift in the response, by the way, I calculated that here. If I expected the mean response to be 10 and I want to determine whether or not treatment A changes that response by 10%, then 10% of 10 is just 1. It's a 1-unit shift. Does that make sense? So I want to be able to determine whether or not my treatment results in an increase of 1 or a decrease of 1 in either direction. If I had an idea beforehand that it should result in an increase, or if that's the only shift that's meaningful to me, I would do a one-sided test. But in this case, I'm interested in shifts in either direction, so I'm doing a 2-sided test, which is indicated by the equal to and the non-equal to. In order to fully power this, I have to understand how big this difference between the groups is relative to the variability in my outcome that I'm measuring. This is what's called an effect size. So if this difference of 1 is small relative to the noise in the data, then I'm going to have a lot of data to find it. But if this difference of 1 is actually big relative to the variability or the noise in my data, I won't have to have as much information or as much data to detect it. So these effect sizes take into account not only the magnitude of the difference that you want to see, or that you actually do see, but the variability in the outcome that you're using to measure the difference. A common effect size for the 2-sample t-test is Cohen's d. Cohen's d is just, on the top here, it's just the difference between the two groups' means divided by the standard deviation of the data. So Cohen's d is just a standard deviation. And the way that you interpret it is that the magnitude of the difference that I observed between my groups is equivalent to d standard deviations of the data. For instance, if I observed a d equal to 0.2, in other words, the difference between mu1 and mu2 divided by the standard deviation of the data is 0.2, then I observed a difference between treatment A and the control that is equivalent to 0.2 standard deviations of that outcome. And that may or may not be clinically meaningful to you. The bigger that D, the bigger the standard deviation difference, obviously the bigger that signal is in the noise. My point being here is that we very often rely on these terms of a small effect or a medium effect or a large effect, and we use these standardized scales. D is equal to 0.2 to be small, D is equal to 0.5 to be medium or moderate, D is equal to 0.8 to be large. When in reality, we need to get away from that. We need to take and determine what the difference is, how big it is or how relevant it is relative to the context that we're in. So if you really need to see something that's at least one standard deviation of your outcome, then that would be, in your opinion, a clinically meaningful effect size, whether or not it's small or large. It may be that these small differences are something that you're actually after. So I would steer away of actually using those cutoff points, but you can still use D to interpret the magnitude of the change that you either observed or that you're trying to power for. And I have some information here. As your difference between your groups increases, obviously D increases. As your sample size increases, the D, or the effect size that you can observe, decreases. So you're able to detect smaller differences or smaller signals with bigger sample sizes. As the noise or the variability increases, you're also decreasing your D. So as your noise increases, you're decreasing the size, increasing the size of the effect that you can observe. So let's use the power.t.test function. We'll finish here in our studio to determine what's the power, what's the sample size that I need in order to have a sufficiently powered test of these two groups in order to detect that 1 unit difference. The key here is I either have to set D, what D needs to be, in terms of the standard deviation of the difference that I need to detect, or I can go use preliminary data that I've collected or that's been published in the literature to estimate what that variability is. And I'm going to assume that we have preliminary data from a small pilot study that tells us that this outcome that we're measuring has a standard deviation of approximately 2.1. Using that information and the fact that I want to see a 1 unit difference at 80% power at the 5% level of significance, I'm going to use the power.t.test function in RStudio. I'm going to connect to my desktop, so give me a moment. So if you have downloaded RStudio, it's actually a very easy analysis tool. The way that it looks is that you have information over here that if you search for a function that you need help with, it will show up over here. If you have data sets that you want to upload into R, they're over here. If you have other code that you've written that you want to upload, it's all over here. R operates as a calculator, so I could do 1 plus 3 and get the result immediately. So I can work in it in interactive mode, which is how I'm going to interface with it right now. I could also pull up code that I've written and run it without typing into the console window. But the function that I'm going to use today, the way that I use R help, and I know that you got, let me zoom in here actually. Is that a little bit better to see? So I'm going to call on the R help by typing a question mark, and I'm going to ask, how do I do power? The nice thing about R is that it will try to think ahead and give me different functions that I can actually use. There's a power function, and it tells me a description of that function. There's a power for ANOVA, and a power for a test of proportions, and a power for the t-test. So I want to use this t-test, which tells me that it will compute the power of a 1 or 2 sample t-test, or determine the parameters to obtain a targeted power. I can get additional help that would show up over on the right-hand side, but I'm going to actually just use the function. So the power.t.test, we'll actually let it pull up the help over here on the right-hand side. The power.t.test is just a function, and I have to give it some inputs. I have to either give it the sample size that I'm working with. Let's say I have 50 subjects, so n would be equal to 50. The delta, which is the difference that I want to see, either the change within a group or the change between groups. For us, that's going to be 1. The standard deviation is that estimate of the variability we were just talking about, which we're going to set at 2.1. The significance level and the power. There are also some other issues, some other things here. You can tell it you want it to be a 2-sample or a 1-sample test or a paired t-test. You may have a 2-sided test or a 1-sided test. We're going to do a 2-sided test. So the way that we call on this, I don't know the sample size, so I'm going to leave that blank, but I do know that I want to see a difference of 1. I assume my standard deviation is 2.1 based on my preliminary data. The significance level, I'm going to leave it at the default, that common 0.05 level. And I'm going to assume 80% power. I'm doing a 2-sample test. And I'm interested in shifts in either direction, so I'm using what's called a 2-sided test. The rest of the stuff we're going to ignore. We don't really need anything else. If I hit enter, it will, since this is like a calculator, immediately produce some results that I can interpret. This tells me I've done a 2-sample t-test power calculation for a change between the two groups or a difference between the groups of delta equal 1, assuming that the outcome measurement has a standard deviation of about 2.1. Alpha is 0.05, power is 0.8, and I've done a 2-sided test. So I should be able to detect with statistical significance a shift of 1 in either a positive or negative direction. And it gives me a note. N, the sample size it's calculated, is the number required in each group. So I have an N of 70.2 or 71 subjects required in both groups in order to have power to detect a difference between treatment A and placebo. The key here is 71 subjects per group. Once I get their data, assuming that my estimate of the standard deviation of the data, the noise in the data, is about right, and the difference is actually there, the difference of 1 is actually there, I should be able to do a t-test on that data and produce a statistically significant result. If the difference is not there, I should not produce a statistically significant result. Should not. Still could, but should not, depending on, again, my assumptions about the variability in the data. What if I have actual data? Let's say I have 71 observations. I'm just using a function in R to generate some random data that has a mean of 9 and a standard deviation of 2.1. So that's data for our treatment, or our placebo, our treatment group, excuse me. And my 71 observations from my placebo group gave me exactly what I expected, a mean of 10 and a standard deviation of 2.1. I can do a t-test comparing X and Y a 2-sided t-test. And what is my p-value? It didn't give me what I expected. That's the way it always works. Why did it not? 71 observations, 9 and 10, 2.1 is my standard deviation. Because I generated data. Notice, this is one of those, this actually is a perfect way to demonstrate what those error rates mean. Just because you have got an alpha of 0.05 and a power of 80% doesn't mean that you couldn't randomly, just by chance, get data with that feature, a difference of 1 and a standard deviation of 2.1 that doesn't produce a statistically significant difference. Notice my difference is 9.35, versus 9.62, which is not a difference, not a shift of 1, even though the truth was 9 and 10. So this is a good way to demonstrate the idea of sampling variation. You won't always get a sample that will give you an adequate or an accurate answer to your question, even if you'd have that true difference of 9 and 10 with the assumed standard deviation. Because what ended up happening is, just by chance, the one group that had a mean of 9 ended up with data that was a little bit higher than a mean of 9, and the one group that had a mean of 10 ended up with data that was a little bit less than. So I could produce another sample and end up with a two-sided test of significance.
You have like a 5% chance of that happening?
You have a 5%, yeah. So there's 5% of all possible samples would produce an incorrect decision, and this is one of those samples. So even though I didn't plan it to be this way, and I did several of these actually leading up to the preparation for this, each of those random samples produced a statistically significant p-value, but this is one of the 5% that doesn't. So actually it ended up being a good thing. We could try it again and watch it make me a liar. X. We're going to randomly sample 2 different ones. We'll do a t-test again. Please be right. Ah, looky there. So this ended up being a little bit more useful than I had intended it to be. Notice the same truth exists, right? 9, a sample of size 71 with a mean of 9 and a standard deviation of 2.1, another sample of 71 with a mean of 10. I'm comparing those 2 groups, and these are random samples from the same population with this mean of 9 and this mean of 10. One produces a p-value of 0.4, one produces a p-value of 0.006. I'm going to guess if I did this again, I would get another statistically significant difference. This sample that produced this non-statistically significant result is a rare sample that could be drawn from this population, because we've set up our analysis to only have that occur about 5% of the time. If I did this over and over and over again, let's say I did it 100 times, I would get about 5 cases where I would get a p-value greater than 0.05. But I will end here because we're right at 11 o'clock. I wanted to open up RStudio and show you how easy it is to work with. I know many of you probably do t-tests. There is a t.test function in RStudio. You can do a quick help search for it and see a little bit about what that t-test function does. And there is a test to power a t-test, or excuse me, a function to power the t-test called power.t.test. And we'll do some more of this next time. Any questions? No? Okay. Thank you all for coming, and I'll see you next Friday.
Can anybody download that RStudio from like KC book, right? If you're
You know what? It's free to anybody. You can download it on your machine at home. And I think I mentioned that last time, but I didn't reiterate that this time. If you just go to Google and type in RStudio, it's right there.
Okay.
And you can download, what it requires is you to download the language R, and then download this interface with R called RStudio.
Okay.
And it's free to anybody.
Okay, great. Thanks.
Actually, it downloads in like 3 minutes. So.
Thank you very much.
Give me just a second, guys. I want to stop sharing and then stop recording.